Hello, welcome to the new Clinician Development Program. Congratulations on your new position and welcome aboard. Again, welcome aboard. My name is James Lewis. I am the Director of Professional and Clinical Development for ITC. And today we're going to cover our first topic, discussing subjective interviews and with some specific goals to reinforce the foundational orthopedic assessment skills that you possess, as well as integrating professional behaviors into your clinical practice. We will further provide some hands-on practice and feedback with one-on-one times with your local mentor. This program will be explained to you in a subsequent video. We're also going to look at some case studies that you'll have access to download. And then upon the completion of this session, we hope that you'll be able to perform a focused subjective assessment, including a subjective history, discovering the nature and the behavior of the patient's problem, be able to use verbal and nonverbal communication effectively during your patient interview, and also apply clinical reasoning to formulate a basic assessment related to the subjective history and what the actual tissue impairment may be. During today's topic, we're going to cover material presented in an article from Peterson in 2021. You can use the QR code here on the slide to download that handout. The reference article itself is listed here in this QR code if you would like to download a copy of the actual article. So here we are. We're going to get started with kind of going through the student handout. So if you'd like to get that ready to go. And then we will continue with SINSS, being an acronym that stands for severity, irritability, nature, stage of condition, as well as the stability of the condition. If we looked at subject reactivity or severity, at its core, it's a way to grade a patient's functionality. We need to grade each functional activity that the patient is telling us they're having difficulty with. For example, somebody with a sprained ankle may have difficulty with not only walking, but also going up and down stairs or standing on one foot to put on their shoes and socks. They may have to sit down. And so those activities can all be graded, and we can come up with a way to tell someone about their severity of their injury and how it affects their function. This then gives us or gives rise to the ability to make patient goals. If we look at how do we categorize this severity, we have three different levels: high, moderate, and low. We use specific questions during the subjective interview to discover which category our patient may fall into. For instance, with a high subject reactivity or severity, the patient may say, I am unable to do this activity because of this discomfort, this pain that I have. Now, understanding that subject reactivity, subject severity, those are interchangeable words. You may hear me use both of them, but we'll say that subject severity, the severity of their injury from a functional standpoint, if it's high, means that they are unable to perform it. If it's moderate, it means that they are able to perform the activity, but will most likely experience some pain or have to modify the activity in some way. And for low reactivity, the patient can carry out the activity as expected without having to modify it or without pain that changes the way they perform it. Now, during this low category, it doesn't mean they don't have pain, but the pain that they have does not keep them from changing the functional activity. And they may or may not experience discomfort after the activity. So if we looked at severity for the following, number one, a sales representative is not able to ascend stairs to the second floor where his office is located. Because they're unable to ascend the stairs, we would say this is high. A mother complains of terrible shoulder pain after a fall and experienced primarily when she attempts to pick up her 1-year-old son. She is continuing to care for her child normally despite the pain. We might say that would be moderate. And then a soccer player sprained the ankle 4 weeks ago. She began running this past week with no pain. Obviously, that would then be low. If we move on to the next piece, that's going to be subject reactivity. Once you've identified the tissue that is the problem, for instance, if we're looking at our sprained ankle example again, we may begin to see irritability in particular tissues as we move through the passive range of motion activities, which puts stress on the activity. For instance, the anterior talofibular ligament may be stressed as we move the ankle into inversion. And that reactivity is then going to tell us how aggressive or conservative our treatment may want to be. We discover tissue reactivity, how much stress it takes to provoke someone's pain by performing tensile loading or lengthening activities. Those are specifically things like passive range of motion in a classical sense, where we take the joint through its movements and look for end feels. Another one might be a muscle length test, where we may look for length of the everters. In an inversion ankle sprain, the everters may also be stretched and or injured. And passive range of motion accessory, where we're looking at the specific component motions of the joint itself. For instance, with an inversion ankle sprain, we're looking at the ability of the talus to perform its component motions. Those activities will then guide us or help us gauge how aggressive or conservative our treatment should be. So we can also now classify tissue reactivity as high, moderate, or low, and you can see the definitions listed there. Essentially, high is where pain is reported before the point at which we can determine an end feel. It is often called an empty end feel. Moderate tissue reactivity is pain reported at the end feel, and then low tissue reactivity, there is no pain. We're able to assess a good, firm capsular ligamentous end feel if we continue with our ankle example. The real application clinically comes from the ability to determine how much tensile loading that tissue can tolerate, helping guide our treatment. For instance, if we have a high tissue reactivity and a high severity, we would be less likely to push somebody into active strengthening, as opposed to somebody who is low severity. They don't have really any pain. They actually have even self-selected to start doing some activities. and they have low irritability of the tissue, it takes multiple repetitions or several minutes worth of activity before the tissue starts to react, that person may be ready to progress to the next level in their rehabilitation. So here are some examples, again on a separate slide that we talked about our sprained anterior talofibular ligament. You can kind of read through those at your own pace. You can stop the video if you'd like to kind of read those. We're going to carry on with our next slide. The N in the SINSS moniker, it stands for nature. It's a broad term that includes specific diagnoses or conditions that the patient may be experiencing. It really focuses on the nature of the pain itself. For instance, if we had somebody with a mechanical, what we might call musculoskeletal problem, every time we stressed the anterior talofibular ligament into this inversion movement, we would get a mechanical nociceptive response that was both consistent and predictable, as opposed to the possibility of another pain generator that may be inconsistent and unpredictable, would be much harder to categorize, therefore much harder to treat. We have other categories of pain which can be neurogenic. We can have such as a nerve being pressed or compromised as it maybe exits one of our soft tissue tunnels. Think carpal tunnel, bony tunnels as well. For instance, spinal foramen, where we might have the nerve being impacted by a ligament or a herniated disc. Our next category would be viscerogenic. I think that's fairly self-explanatory, where we would have maybe the lungs or one of our other internal organs producing pain that is mimicking or masquerading as a musculoskeletal. We have some additional categories such as central and autonomic pain that can show up as musculoskeletal symptoms, as well as affective pain that the psychomotor, psychological symptoms are manifest as physical symptoms. So if we look closer at the nature of pain, it really helps us to understand or ask the question, what am I dealing with? What type of pain? What specific condition and pathology? And then what are the patient characteristics, how they're dealing with it, as well as their socioeconomic personality, and is there anything else that may be spurring them to have this discomfort, such as do they have a litigation case that is currently ongoing? That could be a yellow or even an orange flag from a psychological standpoint that would help us better understand their case. And then finally, we have red flags and comorbidities that we need to be aware of. So in the first of the last two S's, we have stage of condition. It is essentially the clinical behavior and the phase of healing. And we have to differentiate these two terms and realize that they're not the same. How someone presents clinically takes into account a lot of the other things on the previous slide, whereas the phase of healing is the time frame from the actual injury itself. So if we look specifically at healing time frames, we see a lot of the healing occur within the first 2 weeks, where they're moving from acute to subacute, where now we have, again, another additional 30% of the healing that's now occurred within the first 6 weeks to give us a total of 80%. And then really by the 10th, 12th week, we have nearly 100% of the healing that's occurred. I like to sometimes use the analogy of 1% per day. That helps people understand, so that it may take 90 days, which would be roughly 12 weeks, to see somebody improving to the point where they're feeling really good and maybe thinking about discharge from therapy. So the phases of healing, again, from this article by Peterson, we can look at the phases of healing that we will see. Inflammatory acute phase typically lasts from the time of injury 3 to 14 days afterwards. It's also called the inflammatory stage. As we move further away from the injury, now we're 2 weeks to 2 months out. We're seeing this subacute phase come in. This is where we have the proliferation of tissue really starting to kind of try and heal the injury itself. And then that tissue begins to remodel as we move into this greater than 2 months out, which has been given the name chronic phase, but understanding that chronic is not necessarily a bad word in this stage. It is just what we call it. Okay, so the phases of healing now versus the actual clinical behavior that someone may have when they are in that particular phase. So it's how are they presenting clinically? If somebody was in the inflammatory phase, which we also call the acute phase, they may be saying that they have redness. They notice redness. Maybe the joint is a little warm. There's obviously swelling. Their function may be even declining. It may be worsening. And their pain level may actually be going up. Think about the ankle sprain analogy that we've been using. How often have you heard somebody with an ankle sprain late in the evening and the next morning they wake up and it's worse, right? They've had time to swell. They've had time for all these acute things to set in. And now they're even having trouble walking, whereas yesterday, after the injury, they were able to walk off the field and put weight on it and so forth. And so then today they get up and the ankle has had a chance to really swell overnight. It's now much more uncomfortable and they feel as if they can't put weight on it. Our last S is the stage of condition and or the clinical behavior. If we look at, again, acute, this would be behavior that we're discussing now. So how they present, the condition is worsening. Their signs and symptoms, they may be not improving. Cardinal signs may be present. We've got associated phase of healing. They're in this active inflammatory phase, and therefore our treatment may be to decrease those symptoms of this acute phase. Now in the subacute behavior, you may see somebody with things that are starting to improve. Their signs and symptoms as they come in each day may be saying that they're beginning to improve. Hey, it doesn't hurt as much. Feels like the warmth is going away. Maybe the redness is decreasing. Swelling still may be present, but doesn't mean that they're not getting better. And they're slowly starting to move into additional activities that we can do to kind of facilitate the healing process. And then a chronic behavior. In other words, they have moved into this new phase, which we call chronic, meaning that they're just progressing as we anticipate. Their symptoms may persist, but they're still getting better. There is still the potential for the tissue to fully heal. The tissue is no longer fragile, And we're now really starting to get into some corrective treatments. Their swelling is near resolved. Their pain is absent, maybe only at the end range or when we really stress it. The associated phase of healing is going to be remodeling, and then their treatment is going to be corrective in nature. Now, here is the chronic word that maybe most of you associate with a condition where the signs and symptoms for the patient have become persistent after the normal healing phase has occurred. So this person has moved through a time away from the injury that's appropriate for healing to occur, yet symptoms persist. So you may see this person is now 12 to 15 weeks post-injury, post-primary healing, when we would consider that finished in most normal circumstances, but they may have developed abnormal pain behaviors or an emotional response where a small noxious stimuli causes the same amount of pain despite healing being considered finished. The patient becomes depressed or despondent due to their perceived continued pain and the chronicity of the condition. Their healing may be complete, but it's had a poor outcome due to possibility of incorrect healing. Maybe there's something else going on, something that we need to let the doctor know about. Has there been a malunion or some kind of adhesions form where we can't get the ankle to move? Are there associated psychosocial factors that benefit the patient being injured? Is there litigation? Is there something else going on? Or have they just become so conditioned to pain that they actually have allowed their central nervous system, and it's not necessarily allowing it to occur, but the central nervous system has now an increased excitability of those neurons in that area so that the normal pathways have become sensitized. Our treatment here has to change as well. We have to start to recognize these things as they're occurring and then address not only the affected region of the body, but also those affected domains up here that we talked about with the psychosocial factors. So here we have a summary page where we go through and talk about acute, subacute, chronic, and then a chronic condition. And you can kind of read over that. So we have one more stage of condition to kind of talk about, and that is the chronic condition. We've had an ankle sprain. We've gone through the normal healing, and we go back to activity, and unfortunately we re-injured it. We had an acute flare-up of an episode. So this would be considered a new injury. They would be acute again. They would have all of those associated signs and symptoms and limitations, but yet it was a chronic condition that was still kind of in a healing phase. And so now we have what we call an acute injury of a chronic condition, or we call it acute on chronic irritation. One little note here about immobilization. Once you've been immobilized and you come out of that cast or brace, you are essentially in the subacute behavior because the tissue is still fragile and it has not had any stress put through it while it was immobilized. So now if we look at treatment itself based on the phase of healing and or the stage of condition, we can see that we get some generalities, some general guidelines. For instance, if we feel like we are in the acute or inflammatory stage of healing and condition, we would maybe want to control inflammation, avoid painful positions, and then try and restore full passive range of motion as our first goal. gentle isometric strengthening and setting, we can reduce muscle atrophy, maybe maintain aerobic fitness through some activities that allow aerobic conditioning, but they don't stress the healing tissue. For instance, for the ankle patient, maybe you put them on the upper body bicycle and allow them to get a little bit of elevated heart rate so that they feel as if they're being productive while they're relatively resting the ankle and lower extremity. As someone moves into the next phase, you can decrease the use of those passive modalities and techniques, move into progressive healing, progressive stressing of those structures. And then this is where we really start to provide some corrective activities that will help not only from a motor control standpoint, but active range of motion and improve the healing of the new collagen that's being laid down. And then, of course, our chronic stage, our remodeling stage, it's a gradual return to pain-free activity and trying to affect all of the psychosocial pieces so that someone does not stay in a chronic psychosocial behavior pattern, but they are effectively moving away from that and into a feeling that they are 100%. So lastly, we have the stability of the condition. The stability of the condition essentially is a patient's progression over time. Are they progressing? Are they regressing? Or are they unchanged? One of the things that you might say in your assessment, this patient is progressing as anticipated. Your knee pain is less, the swelling is improved, and the range of motion is improving 2 weeks after surgery. Those are all objective pieces that we can then put a number to. The range of motion is improved, the circumferential swelling around the knee is decreased, and their visual analog scale or their 1 out of 10 number on their pain is also improved. Or they may progress they may not progress as expected. In other words, they may be moving at a slower rate due to those things that we just mentioned. And these things are keeping them in the acute stage. Maybe they're not doing things as we ask, or they're having continued discomfort because something is not fully improving from a swelling standpoint. Maybe they have some other things that need to be assessed at the joint. Maybe the kneecap is not moving. We need to mobilize the kneecap, or they may have a bit of a superficial infection, or they could have some other things that end up being red flags, such as DVTs and so forth. Again, progression not as expected. We need to really be starting to kind of look at some of these things, whether it's swelling, fear avoidance, the psychosocial pieces that are keeping them in this acute stage. And then at some point, you need to ask yourself, when should we begin to communicate with the physician? And in most cases, sooner is better than later, so that the physician is aware of what's happening with the patient, even though it may be something relatively minor that's going to keep them progressing at a slower rate, but they are progressing. We just want the physician to know that, hey, at their 4-week checkup, they may not be able to do this because it's taken them a little bit longer just to get off the crutches, or some form of fashion of that kind of piece of communication to the physician will actually help them in that follow-up. So again, sooner rather than later on the communication. And then ultimately what you're looking for is, as the clinician, you're constantly asking yourself, is this condition progressing? Or is it worsening? Or they may go through periods of time where they're relatively stable, they're unchanged for a period of 2 to 3 weeks, but they're not regressing. They're just unchanged at this point. They may have good range of motion, their pain is not too bad, their swelling is not getting worse with the activities that you're doing in the clinic or the daily life activities. They're essentially continuing to move through the remodeling process, but they're not quickly progressing as they were when they went from acute to subacute. Or is it unable to be determined? Are they good one day, bad the next? Symptoms change from side to side. They move from central to a lateral discomfort. You see this sometimes with neck and back patients. Is it erratic? Their stability is erratic. A lot of times you will start to see cognitive affective behaviors as well. People will start to mention that they may feel hopeless, desperate. There'll be some despair in their comments, and you can start to have discussions with them regarding those types of issues, behaviors, and if needed, refer them out to appropriate psychological counseling, all the while keeping the doctor informed. So at this point, you can stop the video and download the case study for the SINSS, and I will cover that in a separate video. That is all for this video. Thank you.